We are with Dr. Dave Janz again at University Medical Center in New Orleans. A few updates on what's been going on. So our ICU patients have stabilized. We've been at a stable number of ICU COVID and PUI patients for about 7 days now. Seems like the social distancing is working, as well as a lot of our treatments seem to be keeping people out or getting them out of the ICU relatively quickly. And these are numbers now based on our true COVID positive patients. So these are only numbers that were confirmed positive cases by the Office of Public Health. And these are patients from March, so 3/10 until 4/1. We've had about a 40% extubation rate, about a 40% rate of demise. So 40% of our patients that get intubated decease. And we've kept around 20% of our COVID positive patients on either BiPAP or high flow nasal cannula. So patients in the ICU, 20% of them are able to be held off from intubating. I know we've had a lot of questions about some of our methodologies using BiPAP and high flow nasal cannula. So we're going to address some of it today, as well as just some other updates from Dr. Janz.
Good. Thanks for the introduction. What you can see on your screen right now, you'll recognize as my terrible handwriting from the last video. That's just to orient you again to the discussion. I've now replaced it with images that look a lot cleaner, where you can actually read the writing. And here is a better figure of the drawing that we were using last time to discuss the evidence-based management of these patients. And just again, to orient you to this drawing here on the left side of this figure, this is when a patient gets admitted to the ICU. And we can see that there is a fair number of patients, like Dr. Mackey noted, where they don't need to be intubated at all. And we've been supporting those patients with either high flow nasal cannulas or non-invasive positive pressure ventilation. And we're going to talk about both those modalities in a little bit more detail in a few slides. But in the patients who do require intubation, again, we talked about this timeline of non-invasive mechanical ventilation and the number of evidence-based interventions that we provide to these patients, all the way to hopefully them getting extubated and again, using advanced support devices to help extubate these patients. So that's hopefully where we end up in the patients that do require intubation. There was some questions about the evidence that we talked about in this timeline last time, so I figured we would address some of those questions. This is a figure of our guidelines that we've issued to our critical care providers. It's basically just a more detailed version of the evidence-based timeline that I showed you on the previous slide. So we have, again, providing patients with reasonable tidal volumes, managing their acidemia if they have acidemia at all, providing patients with high amounts of PEEP. If that doesn't do the job in maintaining an oxygen saturation and a lower FiO2, then adding prone positioning. And again, the details are there on the screen. The fluid management of these patients. Again, we're volume resuscitating patients who have some marked sign of hypovolemia, but otherwise we're trying to limit the amount of volume resuscitation we give them. We talked about Lasix dosing last time a bit, and patients who may or may not need dialysis. And then finally, a sedation management strategy shown here. So again, just another figure of how we've been managing these patients. One question that I've gotten quite a bit since our last video is exactly what does high PEEP mean when we're using high amounts of PEEP in patients who are on the ventilator and intubated. This is from the ARDS ventilator guidelines for patients who have ARDS. And you can see that on the screen, there is either lower amounts of PEEP, as shown here, and then higher amounts of PEEP, shown here. And traditionally, the evidence would suggest that patients with moderate to severe ARDS, patients with PaO2 to FiO2 ratios of less than 150, there is some evidence to suggest those are the patients who benefit from higher amounts of PEEP, and this is the high PEEP, low FiO2 ladder that we've been using to manage these COVID patients if they have moderate to severe ARDS. If they have PF ratios of less than 150, and you can see that as you're increasing on the PEEP ladder in regards to the amounts of FiO2 you're giving these patients, you're just much more quickly getting to higher and higher levels of PEEP. So, for example, if patients are on 50% FiO2, your PEEP there is already in the 16 range. If patients are truly requiring 100% FiO2, the PEEP there is as much as 24. So at lower amounts of FiO2, you're getting to higher amounts of PEEP. And when you get to all the way to 100% FiO2, then your PEEP should be definitely in the low 20s. Again, for patients with moderate to severe ARDS, with a PF ratio of less than 150. The PF ratio is another question that has come up since the last video we did. So traditionally, the severity of ARDS, mild, moderate, and severe, has been based on PF ratios of less than 300, less than 200, less than 100. The interventions of high PEEP and knowing the PF ratio to decide if you're going to use high PEEP or not is based on the PF ratio. And deciding whether or not you're going to prone a patient in randomized trials has been based on a PF ratio. The difficulty with PF ratios is it requires you to actually measure an arterial blood gas in patients, which is invasive, it's painful, it is a resource. You have to, someone has to go measure that. If you do lots of them, it does phlebotomize the patient and likely contributes to the anemia that develops in the ICU. So some folks, this is a group from Utah and Vanderbilt, Sam Brown's from Utah, they've developed ways where without getting blood gases, can we just use the arterial oxygen saturation that you measure on a finger probe or on the earlobe or on the forehead, that are non-invasive arterial oxygen saturation? Can you use that instead of a blood gas to then extrapolate what the PF ratio would be using basically very complex math? So you can see that in the top corner here, this relationship is nonlinear, the relationship between the PF ratio and the SF ratio. People like me who aren't very good at math, I'm not smart enough to memorize and apply the mathematical formulas that are required to basically extrapolate what the PF ratio would be based on what the patient's arterial oxygen saturation is and what the patient's FiO2 is. And that's where this helpful table comes in that's on the screen right now. So on the left-hand side, on the y-axis, this is what the arterial oxygen saturation measured non-invasively in a patient who is wearing a finger sat probe or the sat probe on the forehead or earlobe, etc. That's the oxygen saturation that's being measured. And then across the x-axis up top here, this is the actual FiO2 that the patient is on. And so you can see that if the patient's arterial oxygen saturation is in the range of 80% to 96%, and you know how much FiO2 they're on, you can then find the number on this table that tells you, that basically does the math for you and tells you what would their PF ratio be based on their arterial oxygen saturation and FiO2. So for example, if you have a patient on their finger oxygen saturation probe, their oxygen saturation is measured at 90%, and they're on the ventilator, and their FiO2 on the ventilator is dialed in at 40%. If we do the complex math, based on that arterial oxygen saturation, FiO2, then subsequently their PF ratio would be extrapolated to be 147. So these numbers that are in the boxes here are what would the PF ratio be if we plug in the SAT and the FiO2 into these complex mathematical equations. The numbers in these boxes are not the SaO2 divided by the FiO2. This is basically doing the math for us and making it easy for us. So again, another example, if your patient on the ventilator is satting 93%, and the patient is on 60% FiO2, then using this complex math, that would extrapolate to say their PF ratio would be 112 and would be a patient, therefore, you'd consider using higher amounts of PEEP. And if that doesn't do the job to get their PF ratio greater than 112, then you would perhaps pick prone positioning to treat that patient. And now you can decide on those therapies without having to get any arterial blood gases at all. Other questions that have come up. So this is from the Surviving Sepsis campaign. They've released their own guidelines. They have guidelines in regards to how we should manage sepsis and septic shock prior to COVID, and now they've released specific Surviving Sepsis campaign guidelines in regards to how to manage specifically the COVID patient. And this is a summary of initially managing the respiratory failure that comes along with patients who have COVID that's causing pneumonia and respiratory failure. So a few things to point out. Let's start on the left side of the screen. They recommend intubating patients that we think need it. If they have an indication for endotracheal intubation, they recommend an expert in airway procedure performance to do that. Basically, the way we operationalize this is the person in the vicinity of the patient, for example, in the ICU, who's most experienced at performing this procedure, will perform this procedure. We learned pretty early on, though, that like on a good day, intubation of critically ill adults is not a one-person procedure. It's usually a team procedure. And even in COVID patients, a fair number of these patients will have cardiovascular collapse when you intubate them. On a good day in critically ill adults, about 25% of patients, even if you get the tube in the airway in the first go-round, about 25% of patients will develop cardiopulmonary collapse. Not cardiac arrest, but they'll desaturate to a significant degree, and or they'll develop shock during this procedure. You just need an extra pair of hands around. So the person intubating isn't going to be able to manage the hemodynamics while they're trying to get the tube in the airway. It's helpful to have another person around to say this patient now needs vasopressors, this patient now needs volume resuscitation, etc., to manage the hemodynamics and the cardiopulmonary collapse that's common in these patients and all critically ill patients that undergo intubation. They recommend video laryngoscopy to keep the intubator's face away from the airway, which seems like a perfectly reasonable intubation. And that's something that we've been trying to do routinely. We've not always had enough video laryngoscope blades available. Sometimes when these patients come in quickly, we would quickly run out of materials and we would have to use direct laryngoscopy. But at the very least, we'd aim to use video laryngoscopy as much as we can. So that's if a patient's getting intubated. If they don't need to be intubated because they're tolerating supplemental oxygen, then just keep doing that. Keep letting them tolerate supplemental oxygen. If they're not tolerating supplemental oxygen, here you can see that there's a consideration for using high flow nasal cannula. And the reason that that recommendation is in there for considering using high flow nasal cannula is from the evidence that's guided that recommendation is from this trial, which was called the Florali trial. This was This is pre-COVID. This is in patients who are admitted with acute hypoxemic respiratory failure. Most common cause of that acute hypoxemic respiratory failure was community-acquired pneumonia. These patients are presenting to the ED with acute hypoxemic respiratory failure, and they ask the question, which oxygen support device is the best device to use to support these patients who mostly have pneumonia causing acute hypoxemic respiratory failure? And you can see the primary outcome of this trial was the cumulative incidence of intubation. And there was, especially in patients who were somewhat sick in the range of a PF ratio of less than 200, that high flow nasal cannula seemed to win in this trial, especially in the patients who were more hypoxemic from their most commonly community-acquired pneumonia, and standard oxygen with a face mask and using non-invasive ventilation. Those patients didn't seem to do as well when it came to requiring intubation. The other thing that was sort of surprising from this trial is high flow oxygen in regards to survival overall, not just in the patients that were more hypoxemic with low PF ratios, but all patients that were enrolled in this trial. There was a significant difference in regards to high flow oxygen having potentially a survival benefit. This was not the primary outcome of this trial. This was a secondary outcome, but still there was significantly increased survival in patients who were randomized to high flow oxygen to support their acute hypoxemic respiratory failure. Another thing to note is patients with heart failure, with COPD, with BC hyperventilation syndrome. In other words, patients who had an indication, other indication to get non-invasive ventilation, those patients were not enrolled in this trial. So if the question is, how do I support patients with hypoxemic respiratory failure due to pneumonia when it occurs in my COPD patient, the current evidence-based answer is you should support that patient with non-invasive ventilation. That the Florali trial did not enroll those patients because we already think we know how we should support their respiratory failure to prevent intubation and hopefully prevent death. So that's where, going back to this recommendation, that's where this recommendation in COVID patients comes from the Surviving Sepsis Campaign. For you considering high flow nasal cannula, the evidence behind that is basically from the Florali trial. If this doesn't work, the Surviving Sepsis Campaign guidelines, they then say consider a trial of non-invasive ventilation and to monitor this closely with short intervals. This is summarized here. So this is the actual text from the Surviving Sepsis Campaign guidelines in treating COVID patients. And you can see that that text specifically says, again, in these COVID-19 patients, if high flow isn't available, which that can be true sometimes in a lot of hospitals. There are hospitals that don't have any of these devices, or there are some hospitals that only have a handful and they can run out, that they suggest a trial of non-invasive positive pressure ventilation with close monitoring. And the reason that this is suggested is we don't yet know the answer of, is BiPAP or high flow the true correct device to support patients with COVID and respiratory failure? And B, this statement here is pretty important, and that is the risk of potential transmission with non-invasive positive pressure to healthcare providers, healthcare workers is unknown. We just don't know if it increases the risk of aerosolization, the risk of transmission to healthcare providers. We don't know if our negative pressure rooms and all of our PPE protects us against this aerosolization, if it does occur or not. It's just an unanswered question. And in the setting of that unanswered question, and in a disease, COVID-19, that is a pandemic that causes respiratory failure in tens of thousands of patients and critical illness from that respiratory failure in tens of thousands of patients, we just can't completely get rid of an entire oxygen support device like non-invasive positive pressure, especially if we have no idea if it does even cause a risk to healthcare providers. And we should just then focus on using it in an evidence-based way and using it safely. This is the guideline recommendation in regards to not preventing intubation with non-invasive positive pressure, but this is, again, prior to the COVID era. This is the ATS chest guideline recommendations on how to liberate patients from mechanical ventilation. So these are patients who are already intubated. The question is, should you use non-invasive ventilation to help them be extubated and remain extubated? And the answer is yes. In patients who are intubated for more than 24 hours, which is almost every COVID patient, that they recommend extubating these patients to preventative NIV, especially in patients who are at high risk for extubation failure, which again is most of these patients with COVID, and they have this as a strong recommendation. So it's just, so non-invasive ventilation is just a device that has evidence to prevent intubation, has evidence to prevent reintubation, and we just need to keep it in our armamentarium in treating these patients. Now, like we talked about before, we should keep using non-invasive ventilation to treat these patients because there's evidence that it works, but we should also be using this responsibly and as safely as possible while we're waiting one day for the answer of does this cause aerosolization or not? Does this cause transmission to healthcare providers or not? We, at least in the meantime, we can use this as safely as possible. And the way we do that is with closed circuit BiPAP. So here is one of our physicians, Dr. Kyle Happel, who's wearing, he's healthy, he's not sick. He's wearing this mask just for demonstration. He is hooked up to the BiPAP machine, which is over here. This is a Philips V60 BiPAP machine. And this machine is hooked up to this tubing here. So a breath is coming through this tubing. The first device we see here, this three-way device, this has a one-way valve in it. So the breath can only be put through that valve in the direction towards the patient, and when the patient exhales, it'll stop the breath from being exhaled back towards the machine. So here the breath goes into the patient. When the patient exhales, the exhalation all goes through this one-way valve and through this viral filter. This is a viral filter here. So that when the patient exhales, the breath travels out through this viral filter and then into the room. Traditional BiPAP or non-invasive setups, and I should alter this to say, I use this term BiPAP interchangeably with non-invasive ventilation, with non-invasive positive pressure ventilation, admitting that they technically aren't the same thing. BiPAP is actually a brand of certain types of devices, but I use them interchangeably. Perhaps I should become more specific as we talk about this more. But for our purpose here, I'm using these things interchangeably. Most of these devices, traditionally, there's usually an elbow adapter here, which is usually open to the room, where this stopper is not in that hole. And when the patient exhales, this is in the pre-COVID era, the patient's exhaled tidal volume would just come out of here into the room, which now we recognize is probably not the best way to be using BiPAP in these patients. So the way that we set these up now is we find elbow adapters that allow us to plug this usual hole that's in the adapter, or elbow adapters that don't have any of those exhalation ports at all. So when the patient exhales, it's all through this closed system, through this viral filter, and out into the room. With a sealed mask around the face, as you see here, and exhaling through this viral filter. it essentially provides the same amount of quote-unquote closed circuitry as an intubated patient on a ventilator does. So when a patient exhales through their endotracheal tube, you have an endotracheal cuff that hopefully has a seal with the wall of the trachea, which theoretically should be the same seal that a BiPAP mask has to the face if everything's perfect. So that seal is anatomically essentially the same thing. And then the route of exhalation in an intubated patient is basically the same, where they'd exhale through their endotracheal tube. And then that exhaled breath would be exhaled through a viral filter that's just in line with the invasive ventilation tubing. And eventually that breath will then make it out into the room, but it's after it passes through a viral filter. So essentially it's the same, where the BiPAP mask here, if there's a perfect seal, and I understand that things aren't perfect in real life and getting a perfect seal is not always possible, but considering a perfectly sealed BiPAP mask to be the same as an ET tube cuff that is perfectly sealed to the wall of trachea, and this viral filter that's on the exhalation limb of the BiPAP mask is essentially the same as the viral filter that's on an invasive ventilator. This is how our workflow in regards to extubating these patients, and we've been operationalizing this. We've recognized that lots of patients who are intubated on the ventilator, traditionally the way we'd extubate patients is we do something called a spontaneous awakening and a spontaneous breathing trial on some pretty minimal amount of support for the patient. So the patient will be spontaneously breathing, we'll turn off their sedation, they'll be spontaneously breathing on this minimal amount of support through their endotracheal tube and with their ventilator. And we'll see whether or not they quote unquote pass a spontaneous breathing trial, and those passing criteria are down in the bottom, the left here. Now, anecdotally, I'd say it's a very rare event for these COVID patients to look great on a spontaneous breathing trial and to pass a spontaneous breathing trial on such minimal amounts of support. And so we've adjusted our care somewhat in that if we do find a COVID patient who looks like they're doing okay on such a minimal amount of support, we do this spontaneous breathing trial for about 30 minutes. And then if they're passing, extubating them to a pretty minimal amount of support, just extubating them to 6 liters nasal cannula. If patients have comorbidities, we talked about this before, the ATS guidelines on extubating patients to BiPAP. If they have comorbidities, high risk for reintubation, and those comorbidities are things like COPD, heart failure, morbid obesity, weakness. Even if they look great on spontaneous breathing trials with such minimal support, we will still then extubate those patients to BiPAP because they do have a higher risk for reintubation. So those patients will still get extubated to BiPAP. But if they don't have any of those high-risk features for reintubation, they're otherwise healthy, and they pass a spontaneous breathing trial, we'll extubate them to 6 liters nasal cannula. Now, most of our patients fall in this category where they are technically failing spontaneous breathing trials because, for example, their respiratory rate is in the 40s, or they're desaturating on this amount of FiO2. This is actually a common event in these COVID patients. And in prior to COVID times, what we would commonly do is just say, well, today's not the day to extubate them, we're going to try again tomorrow. And again, we've recognized that we can't wait forever for patients to look perfect on spontaneous breathing trials to extubate them, because it commonly just won't happen. And there is some evidence to support this practice too. There is a randomized trial of patients who fail breathing trials in this moderate category of then saying, even though they failed the breathing trial, we're going to still then just extubate them to BiPAP. So this is an evidence-based practice. It's not something that we have just completely made up out of the blue. And in that randomized trial, if you extubate those patients who fail a breathing trial to BiPAP, they clearly come off the ventilator quicker than if you don't extubate those patients to BiPAP. And it seemed like it was a safe practice, that those patients extubated to BiPAP weren't getting reintubated at rates that were alarmingly high. So it seems like it's a pretty safe practice. So we apply that evidence in the middle part of this figure here, where if they're failing a spontaneous breathing trial with the endotracheal tube still in place, we'll just give them a little bit more support in the form of more pressure support and PEEP until their respiratory rate becomes less than 35, or their SAT is now greater than 88%. Not to keep them intubated, but to know what BiPAP settings we're going to pick when we extubate them in the next hour or two or later that day. So this patient's still likely going to get extubated, but we're just going to try to make an educated guess as to what BiPAP settings we're going to extubate the patient to. And then after we've extubated that patient, trying at least once, if not more than once a day, trying to get them off the BiPAP to see if they even need it at all. Then finally, we get over here to this category of patients who are on a spontaneous breathing trial, and they just floridly fail the spontaneous breathing trial with some life-threatening decompensation or very significant decompensation that's more than just a slightly higher respiratory rate or a slightly lower oxygen saturation. Some significant amount of quote-unquote failing this spontaneous breathing trial, then we say it's probably just not safe to even try extubating this patient to BiPAP. Let's put them back on a controlled mode of ventilation, keep working on them, and try again tomorrow to see if we can extubate them. This is, again, from the Surviving Sepsis Campaign guidelines on the treatment of COVID patients. Some specific interventions that, again, summarize lots of the things that we've already talked about. So we've already talked about dialing in correct tidal lines for these patients. We haven't talked much about the fact that patients who present with infiltrates in their chest X-ray, we all immediately think of COVID these days, but a cognitive strategy that I've been using with my teams in the ICU is when all these patients present and all we know about them, we don't have their COVID test back yet. All we know about them is they're febrile, they have infiltrates, they have respiratory failure. A cognitive strategy that I've been using with my team is asking them, what would this diagnosis have been 3 months ago? Then, when you prompt your team that way, it forces them to remember non-COVID diagnoses and tries to help them not forget about other things that could be going on, like this could not be COVID at all. This could just be bacterial pneumonia from streptococcus, for example. We've talked about conservative fluid strategies, remembering that patients, before you get their COVID test back, before you've diagnosed the cause of their CAP, that bacterial pneumonia is still a cause of CAP, and we shouldn't forget about it. Again, prompt your teams to think about the question, what would this diagnosis have been 3 months ago? And make sure that you're still considering all those potential diagnoses. We've talked about when we use steroids, and that's in patients who have some other indication for steroids. In this middle column here, we've talked about most of these things, and specifically just again to highlight, there is not a recommendation to use some of these medications like hydroxychloroquine, anti-IL-6 medicines, antivirals. There is not a recommendation out there from the Surviving Sepsis guidelines that you should be using these things because we just don't know if they work or not. So we spend a lot of time focusing on what we know works for these patients, and then it's up to you to decide whether or not you want to use any of those medications. And I think that is it. And I'll take questions from Dr. Mackey.
I actually think you covered every single question. Let me double check. Taking notes. Oh, you covered every question.
Sounds good.
The